Welcome to the Medical Minute podcast. I'm Anne Connell, a Melbourne-based GP.
And I'm Moz Calafella, also a Melbourne-based GP.
So this is our second of three planned podcasts on bone health. But before we go any further, we remind you that our main aim is education and entertainment, and this can't really replace a proper consultation with your own healthcare provider. So we've already done our first podcast, which talked about the things that you can do to help preserve your bones, the things that everyone can and should do. But today we're going to look at more individual risk of minimal trauma fracture. Hey, Dr. Moz.
Yeah, I think hopefully people found the episode on general bone health sort of a helpful foundation for the next two episodes. And today we're going to talk about all the things that can actually sort of impact our bone health over time, and if there are sort of things that people should be paying attention to in their life or when they need to be talking to a doctor.
Absolutely, because the bitter reality is that all men over 50 and all postmenopausal women are losers. Yeah.
Please elaborate before we get a bunch of angry emails.
We're all bone losers, yeah? From the age of 50 or after the menopause, if it's a little later in women, we lose bone. Yeah. And some of us are fast losers and some of us are slow losers. And the risk factors that we were trying to work out, trying to predict to a degree if you will be a fast or a slow loser. So
indeed.
That's why we're losers, yeah.
So for complete clarity, we're not losers in life, or you're not losers in life. I'm not over 50 yet, thanks very much. But you guys aren't losers in life. We still like people over 50. But it's more about bone density loss is what we're talking about. We're all losing
Absolutely.
it.
And some of it is predictable. Yeah. So quick revision. Peak bone mass achieved about the age of 30, usually fairly stable bone mass from 30 to 50, and then we do start losing it. So when we're having a chat to you about your bone mass, we'll actually be trying to be working out whether there's a reason why you didn't achieve a very good peak bone mass early in the piece, or if there's a reason why you might have been losing it in the years that you should have been stable between 30 and 50. So that's where the most of our focused chat will be going when we see you to chat about your individual risk. Minimal trauma fracture, do you want to remind us what that is, Mo?
Yeah, absolutely. So we did cover it in last week's podcast, but minimal trauma fracture is, the way my small brain thinks about it, is a fracture from an injury that shouldn't have caused an injury or a bone break. And so classically we talk about standing height, so 1.5 meters kind of thing, and having a fall and breaking something. And I think, interestingly, in last week's podcast, we talked about that they're probably more common than people think, and about 1 in 4 men who sort of live, beyond the age of 60 will have one. And I think 1 in 2 women we talked about will have a minimal trauma fracture beyond the age of 60, if you live beyond the age of 60.
I think 44% of us will have some form of osteoporotic fracture.
Yeah.
Of the women. Yeah. But before we actually go into it, when you come for that chat, which you probably should come for when you hit the menopause if you're a woman, if you're over 50, if you're a guy. So that's the perfect time to come. But is it worthwhile chat having if you're a bit older and haven't done it, if you're 60, 65, 70? Definitely.
100%. Yeah, 100%. So I think, like we sort of talked about, this is a constant conversation and we're trying to reduce the likelihood that things happen moving forward. And so even if, you hear us talking on the podcast and we say, come see us at age 50 and you are 60, it's not too late to start having a conversation. So we definitely want to see anyone who's concerned about their bone health and talk about the risk factors that they can adjust or manipulate.
But the very first question we'll ask you is if you've already had a minimal trauma fracture. Because it's not that unusual for people to come and say that, yes, they have had one, but that nothing in particular has been done about that the fracture was managed, but the risk of future minimal trauma fracture has not actually been assessed in any particular way and there's not been any particular advice. So that's our very first question.
I guess that sort of reflects sometimes some of the issues around fragmentation in care. You see a bunch of different doctors for a bunch of different things, and everyone thinks that the next person is going to look after it or the last person has already begun looking after it. And so if you've had a minimal trauma fracture and nobody's talked to you about reducing your risk of future ones, you should probably talk to someone.
Yeah. And it is interesting because people sometimes get hung up on, I need to have a bone density scan, I need to see what my T-score is, and then if you get the bone density scan and a T-score is not in the officially osteoporotic range, it's like, cool, I don't have osteoporosis. But there are sort of two different ways of diagnosing osteoporosis, and the one where you've had a fracture before is probably much more valid because your skeleton has already failed. So clearly there's an issue. So the most reliable predictor for having a minimal trauma fracture in the future is having already had one. So if you've had a minimal trauma fracture, you need treatment. But we will do a bone density scan, even though I just said that you need treatment anyway. Why do we do the bone density scan, Moz?
As with many things in the Australian healthcare system, funding, some version of funding is the question mark. But the reality is, it helps us know how we're tracking as well over time in terms of being able to see, hey, did we get better? Did we get worse? How should we be managing things and going from there?
Yes, and having had a minimal trauma fracture does mean that you're automatically eligible for the medications, but there are newer fancy pants medications called anabolics. We'll talk a little tiny bit about in the next podcast. But for those, as well as having had a fracture, you need to have a particular T-score. So we start you with a bone density scan, even if we know that you definitely need treatment, to work out which treatment is the best one for you.
Yeah. But I like that point that you made, Dr. M, because we think about it all the time. So you don't we? So you're sort of thinking to yourself, hey, what are my odds of having a minimal trauma fracture? Well, track record is the king. So if you've already had one, so we need to start thinking about preventing the second.
It is, and I guess it's the comparison that springs to mind for me is cholesterol, because when someone hasn't had a cholesterol-related event, then we decide whether to treat them or not based partly on their actual cholesterol number, taken in the context of what we call the global cardiovascular risk. But once you've had a heart attack, all bets are off. You will be on a statin, a cholesterol-lowering medication. Whatever your cholesterol number, nobody cares. You have had the related problem, therefore your blood vessels need the extra support. And it's the same thing for a minimal trauma fracture. Whatever your bone density, clearly your bones need some help.
Yeah, absolutely. Yeah.
Okay, so we'll move back to the main event. You're coming to see us, you haven't had a minimal trauma fracture, but you're quite interested in your fracture risk. So there are two different groups of conditions that we look at. The first one would be, we would regard as a major risk factor, something that there's a significant chance that it's either stopped you reaching your peak bone mass or caused you to be losing bone between the 30 and 50 when you shouldn't really have. So let's talk about those first. What sort of conditions would come to mind for that?
Yeah, so I think the big ones, I guess, that we think about are if you're a woman having started menopause before the age of 45, and the flip side of that, if you're a bloke having some version of problem with your male hormones at really any age, can impact your bone density. So those are sort of the first two that I think about. And then after that, there's a big, long list, and I'm not sure how much you want to go into the big, long list, but essentially there are a bunch of chronic diseases that let us know that there's some version of immune issue, and we think that sometimes the chemical messages that are involved in those immune diseases end up causing some, disruption in the pathway for you building and sort of accumulating bone density.
So we don't need to do the whole list, but things like thyroid disease and celiac disease would definitely spring to mind, and your inflammatory arthritis. The other thing is if people have spent any significant period of time on prednisolone or equivalent on steroid medication. So really, if you've spent 4 months or more taking steroids over the course of your life, then that's probably unfortunately involved a fair bit of bone loss.
Yeah.
So anyone that comes into any of the categories we just mentioned, the recommendation that you would have a bone density scan, which goes by a number of names. We have a bone density scan, bone densitometry scan, and DEXA scan, and they're all the same thing. Can you think of any other names for that particular scan?
No, I can't. I'm sure, actually, do you know what? I'm sure there's another name for it somewhere in the gym bro world. So all the health junkies, I'm sure they'll have another name for it. And if you know any other names, hit us in the comments.
Scan
Yes.
something very similar. Yeah. So as an aside, in 2024, there were new osteoporosis management and treatment guidelines issued in Australia. And certainly anyone who comes has any of the things that we've just talked about, the recommendation is that you should have a DEXA scan.
Yep.
Let's talk Medicare for 2 seconds. Medicare.
Oh man, Medicare, favorite topic of it. We do our best to cover it every podcast. We love it.
Okay, shall I take this? So the bone density scan, even though the recommendation is that you have it according to the guidelines, won't be funded for everyone. Yeah, we'll not go into the detail of who it will be funded for and who it won't be funded for, but pleasingly, these days a private DEXA scan costs, what, about $150 more?
Yeah, something along those lines.
Annoying.
Yeah, I think most places will do it for under 200. Yeah. And like you've sort of said, it's a very small slice of people that are actually funded in terms of age. So really, if you're 50 years old and talking about your bone density, it is unlikely that you'll get covered for your bone density scan. If you're sort of 70 plus and you're talking about your bone density, you're probably going to be covered. But like with many things, just because Medicare doesn't cover it doesn't mean it's not a good idea, or it doesn't mean that there's not a role for it. And we can definitely talk about that with our patients.
And once you've had your bone density scan, you'll be presented with something called your T-score, which will be a minus number. Can you give us a really straightforward, simple explanation of why that would be, Moz?
Yeah, so look, the T-score essentially is going to be a minus number because it's comparing how your bones go compared to a young peak bone density person. So unless you are a peak bone density person, you're probably going to get a minus score. And so it would not be unusual for most of the patients that we decide to do a bone density scan on to have a negative T-score.
That's correct. So officially, if your T-score is less than minus 2.5, you have osteoporosis. And if it's between minus 1.5, minus 1, my apologies, and minus 2.5, you have osteopenia.
And it's just the stages that the bones go through as they become sort of more brittle. So, we want it to have this thick, beautiful architecture, and then osteopenia, you're starting to lose some of that structure, and then osteoporosis, you've really lost a lot of the supporting structure within the bone.
But it's an interesting system to have chosen because you're comparing you to a healthy young adult. And the reality is that by the age of 60, the typical normal woman will have a T-score of minus 1. And once you're in your 80s, most women will have a T-score around minus 2.5. So that would be what is normal for age. So your T-score isn't your fracture risk. It's quite problematic because a T-score of, say, minus 2.5 in a 50-year-old woman does not have the same fracture risk as a T-score of minus 2.5 in somebody in their 80s. The lady in their 80s will have about 6 times the risk of a fracture as the 50-year-old, even though their T-score is identical.
Yeah.
So it's all a little bit complicated. It's not a perfect predictor. So anyway, the guidelines are T-score less than minus 2.5. You have officially osteoporosis, and some form of treatment will be recommended. And we will talk about that in our next podcast. If your T-score is between minus 1.5 and minus 2.5, so interestingly, not everyone who has osteopenia, but some people who've got the kind of worst grades of osteopenia, it's recommended that the next thing to do is to do something called your FRAX score, which is your fracture risk predictor. And that's to try to cover the bit that I've just said, that the T-score isn't actually your fracture risk.
And so the FRAX score is a really useful calculation that we do, much like we do for heart disease and a whole bunch of other things. And why is it different to just looking at a T-score, Dr. Anne?
Because it takes other things into consideration. It takes your age, your weight, your height, whether you smoke, whether you drink too much alcohol, whether you're a woman or a man. Even includes things like whether a parent has had a hip fracture, whether you have rheumatoid arthritis, whether you have had a long spell on steroids. So it takes the other things that impact your fracture risk. And again, it's not perfect, but it is it certainly gives a more accurate prediction of fracture risk in the next 10 years than T-score alone does. So if you're in that osteopenia, but more than mild osteopenia range, we do your FRAX score, and if your FRAX score shows that you're at high risk of a major osteoporotic fracture, then again the recommendation is that you have some form of treatment, which is going to be what we're talking about next pod. Yeah. But there are some other things that were some more softer predictors, which we'll still want to cover in the consultation. What sort of things would those be, Moz?
So you touched on them with the discussion around the FRAX score. And so it's essentially if you've got a family history or a parent who's had a hip fracture. So, someone else who's had some sort of nasty hip fracture. If you're age 70 or more, so we worry about you there. And then some of the things that we talked about last time, if they continue to be a problem for you. So if you've got reduced mobility, if your muscle mass is low for patients, if you are low body weight, if there's some sort of malnutrition issue, and of course our favourites for all medical history taking, if you're a smoker or if your alcohol intake is significant, then those two things are important as well.
So interesting, the FRAX tool comes in here, at least in the guidelines. It's not that we should send all of you for a bone density scan, but we should do your FRAX score and send you for a bone density scan if your FRAX score indicates. What do you think about that, Moz?
I think it's an excellent example of cost-benefit analyses and bean counters being very judicious with how they spend the taxpayers' money. And so, again, I think this is an instance where I think you and I practice pretty similarly here, that if someone comes in and says, I think I'd like to get a bone density scan, I'm very worried about my bone health, and we look through the criteria and they don't meet the Medicare criteria for a bone density scan, I'm probably ordering a private one, to be honest. We just have one.
When a patient has discussed all the risks, including the possible harms from having a bone density scan, which we'll talk about in a second, if they want to go ahead, I am not going to stand in your way. Definitely not. We're all autonomous thinking adults who the person most interested in your health is yourself. That's what I tell patients every day. We have that acknowledgement in several consultations a day. So if someone wants to have it done, then they can have. And as you say, the cost for this scan at least is not going to be Medicare's concern anyway, because they're not going to get a rebate.
Yeah.
There are, I suppose, possible harms from having a bone density scan. So two lanes of possible harms. The first would be that you might have a problem with insurance if you are given a diagnosis of osteoporosis.
And insurance companies by default are designed to try and minimize the amount of money that they pay out, aren't they? And so, they're going to try and extract more money from you for your annual insurance policy if you tell them that you have any sort of condition. Because once you tell them that you have, poor bones or porous bones, osteopenia or osteoporosis, they're absolutely going to take that into consideration, and they're going to say this person might break their hip or might break their arm, and they might cost us, the insurance company, a significant amount of money while we look after them for that problem. So I think you might pay a nice sum of money for that, and that may never eventuate.
Yeah. So you definitely have to declare it for travel insurance, but also for income protection and for injury policies. If you forget and have a fracture, you're unlikely to be covered at all. And the other little bit of unknown, I suppose, is that you may be therefore be found to have technically osteoporosis by your T-score, and therefore move into the lane of treatment is probably recommended. But we're a bit in a no man's land of knowledge there, that we don't actually know if everyone with a T-score less than -2.5 who hasn't already had a fracture actually needs treatment. So this is all coming back to not everyone with a T-score of -2.5 has the same fracture risk. So there is a chance that if you weren't high risk, just looking at all the things we knew about you, but we decide to do a bone density scan because you'd really like to have one, and your T-score suggests that you have osteoporosis and need treatment, it may be that you're getting exposed to possible harms from the treatment, whereas arguably you didn't need it in the first place. But I hope as the years pass, we will be better able to identify who actually definitely does need treatment, because T-scoring is not perfect. The FRAX calculator is an advancement, but there's definitely the case that it is still a bit rough and ready.
Yeah. And I mean, we'll talk about this next week in a little bit more detail, but the medications that we use, they're not, Panadol and Nurofen. So they do come with some potential for consequence. And so we do want to be careful around who we start people on these medications.
So I think probably covered most of the things as sort of my sort of final comment in the show notes, and wonder how you feel about that. But increasingly, I like to think of it as primary and secondary prevention of minimal trauma fracture, rather than the management of osteoporosis. And the distinction is that because osteoporosis is popularly, and by the World Health Organization, defined mostly in terms of your T-score, it can sometimes be a bit of a red herring. So in my head, I like to think that I'm trying to stop people having their first fracture and preventing them from refracture, and that will frame the discussions that I like to have around.
I think that's a really healthy way to look at it, because ultimately we don't want to live long, arbitrarily, numbers-driven lives. We want to live long, happy, healthy lives, and preventing your first and second fracture and so on and so forth. These are the ways that sort of hopefully we can have a positive influence on people's lives and make sure that they're living happy, healthy, long lives.
Yep. So if you're a man over the age of 50, if you're a woman post-menopause, please have a chat to your usual doctor about your own fracture risk.
Yeah.
To the enjoyment of the rest of your life. Good chat.
Excellent. Good chat. I'll take that as the indirect cue that you have nothing else to add. I too have nothing else to add. If you've made it this far, thank you very much for lending us your ears for the last 20-something odd minutes. Remember that probably the most valuable way that you can help us, if you found the podcast valuable, is to share it with someone. So if you think that any of the stuff that we've said was worth listening to, please send it to someone else so that they can listen to it too. Harass them. If you know us personally, consider it having done us a favor if you've sent the podcast to someone that you like, or if you don't like the podcast, send it to someone that you don't like. And remember to give the podcast a rating on Apple Music and Spotify. And do check out our YouTube page, where we've been trying to put some more shorts up and try and break up the podcast into shorter pieces. Follow us on the socials as well, the Instagram, the Facebook, all that sort of jazz. And with that being said, Dr. Anne, thank you for your time. I'll see you next week.
Thanks for yours, Moz. Thank you.
Ciao.